Thank you for the opportunity to talk about diagnosis of lumbar spinal instability in the context of lumbar stenosis and spondylolisthesis. A recent review of the diagnosis and management of lumbar spinal stenosis documents the high prevalence and disability of this condition. Optimizing treatment would affect many lives. Multiple authorities and societies recommend fusion surgery if there is instability and stenosis. These recommendations are echoed in other reviews. For example, this review also states that preoperative instability is one part of the indications for fusion surgery. A survey of 223 spine surgeons confirms that most all agree that instability is important in deciding how to treat patients with spondylolisthesis and stenosis. Another study documents that these 223 surgeons could be using a wide range of instability definitions. This is further complicated by the multiple thresholds that are used to classify motion as normal or abnormal. Many payer policies give requirements for fusion surgery in lumbar stenosis patients that include requiring evidence of instability. However, payer policies are inconsistent. Several peer-reviewed publications critique diagnostic tests for spinal instability. This one by Leone et al. Arrives at conclusions that are consistent with other reviews. The sensitivity, specificity, predictive value or accuracy of diagnostic tests for instability, as a justification for fusion surgery, is unknown. Leone et al. Also note that it is unlikely that any future agreement of definition, clinical syndromes, and therapeutic regimes can be reached if clinically useful measurements are not a fundamental component of the whole concept of instability. This presents a quandary. How is it possible to determine if spinal instability justifies fusion surgery, when there is no validated diagnostic test for spinal instability? Using this review by Simmons et al., let's consider what might be wrong with instability criteria that have been applied in research and clinical practice. There is modest agreement that intervertebral motion assessed from dynamic radiographs may be the most reliable method. This is likely because abnormal motion on dynamic radiographs informs that the passive intervertebral motion restraints are incompetent. One common approach is to classify a level as unstable if there is greater than 10 degrees of rotation between flexion and extension. However, many investigations have shown that greater than 10 degrees of rotation is very normal in asymptomatic people. It may be argued that greater than 10 degrees is abnormal in symptomatic patients, but data do not support that hypothesis. Another common approach is to assess whether translation is above a threshold. That has several problems, including that both rotation and translation are dependent on how hard a patient tries when asked to flex and extend. A level may be truly unstable, but that was not detected because the patient did not flex and extend sufficiently to use the rotation or translation criteria. Another issue with translation measurements is that radiographic magnification can vary between 20 and 60% in clinical X-rays. If corrections are not made for radiographic magnification, then the translation measurements will have error. Finally, 3 mm of translation may not be a problem in a large male with a very wide vertebra, whereas it is a problem in a petite woman with a small vertebra. As Simmons et al. Concluded, working through the maze of instability criteria is futile if you want high-level evidence. A deep dive into these issues can be found in a preprint on Research Square. Is there a better approach? If so, it must account for variability in patient effort. Account for variability between levels. Account for variability in vertebral sizes. Use solid reliable reference data to differentiate between normal versus abnormal motion. And provide instability metrics that are easily digestible in clinical practice. One option is a metric based on rotation-dependent translation. This metric relies on the data supporting that, in a healthy spine, translation is linearly proportional to rotation, as long as rotation is such that motion is outside of the neutral zone. Rotation and translation can be measured from standardized anatomic landmarks. These landmarks can be automatically detected using artificial intelligence and machine learning, as many investigators have documented. Rotation is measured as the change of the angle between the end plates from one position to another. Translation can be measured at the posterior inferior corner of the superior vertebra in the direction defined by the endplate of the inferior vertebra. This is data for radiographically normal, L4-L5 levels, in asymptomatic volunteers. These data document a fairly linear relationship between translation and rotation. The gray shaded area shows the 95% confidence interval. If rotation was measured to be 10 degrees from flexion to extension, then we can use these data to determine if the measured translation was outside the 95% confidence interval, for the amount of rotation. This gives us the data needed for a diagnostic test based on rotation-dependent translation. Note that this is level-dependent. Different data are used for each different level. So, if rotation was 10 degrees in a patient, and translation was at the upper border of the gray shaded area, then translation was at the upper limit of normal. We can standardize reporting by expressing rotation-dependent translation as the distance from average normal translation in healthy spines. In this case, the standardized translation is 2. We refer to this standardized translation as the foraminal sagittal translation index, or FIST index, because it describes how the posterior inferior corner of the superior vertebra is pounding into the foraminal region. If measured translation is about 11% endplate width, FIST would be about 4, and you would know that the translation is well outside of normal limits. You would not find that amount of translation in a healthy spine. This is an example of normal intervertebral motion. Image stabilization has been applied. Image stabilization involves holding one vertebra in a constant position on the display, as the flexion and extension X-rays are alternately displayed. This makes it easier to appreciate relative motion between vertebrae. Image stabilization can make it easier to discuss a diagnosis with patients. The quantitative metrics are shown. Note that L4, L5 and L5S1 would be classified as unstable using the greater than 10 degree threshold that has been used in many studies, though the motion is normal. When FIST is between -2 and +2, the shear translation is within normal limits. You observe little translation in a healthy spine. Translation is just enough to allow for the rotation that the patient needs. Vertical changes are seen in the foramen, but not translational compression of the foramen. This is an example of abnormal FIST at 2 levels. Excessive intervertebral translation can be observed in the foraminal region both at L3-L4 and at L4-L5. Consider how the translation might be affecting the nerve roots. The translations are just below the upper limit of normal for healthy spines, but when corrected for the somewhat limited rotation, translations are well outside of normal limits. Here is another example of abnormal FIST. It is very abnormal at L3-L4 and L4-L5, and somewhat abnormal at L5-S1. Again, consider what may be happening to the nerve roots between flexion and extension. What difference does it make if the FIST index is abnormal? Since this is a new metric, there is as yet no direct evidence. However, consider the work of Morishita et al. In live patients, during spinal surgery, they placed a pressure transducer in the intravertebral foramen. Then they recorded pressure while the patient was moved into flexed and extended positions. Here is an illustration of transducer placement and the record of pressures. They used compound muscle action potential, abbreviated CMAP, for electrophysiologic monitoring to assess the integrity of motor pathways, and then correlated that with the pressure recordings. They found that patient positioning significantly affected both pressure in the foramen, and increased pressure resulted in deterioration of the latency and amplitude of the CMAPs. In a subsequent experiment, they used the same basic methods, but correlated the pressure measurements with the preoperative symptoms. They concluded that the genesis of intermittent claudication may be affected by the variation in pressure on the nerve roots. It is reasonable to hypothesize that in some patients with a high FIST index, there will be high variations in pressure on the nerve roots, and this may be contributing to symptoms. It is also reasonable to hypothesize that fixing the mechanical abnormalities detected by a high FIST index may provide symptom relief. A diagnostic test for lumbar spinal instability should ideally detect instability in patient populations where it might be expected, but not in populations where instability is not frequently considered. The FIST index was calculated for each level in 7,621 pre-operative flexion extension studies from multiple study types. The proportion of treatment and adjacent levels with FIST greater than 2, and with FIST greater than 3 was calculated. In patient populations where abnormal FIST might be expected, the proportion of abnormalities is much higher than in patient populations, where it would not be expected, since instability was a contraindication in those studies. Note that abnormal FIST was also found in a proportion of adjacent levels. So far, we have been discussing sagittal plane shear translations and the potential clinical significance of abnormalities that can be detected using the FIST index. Multiple investigators have also studied abnormal vertical translations between vertebrae as another form of instability. In a healthy disc, only modest changes in disc height can occur between compression and tension. In a degenerated disc, much larger changes in disc height can occur. The change in disc height can be measured at the anterior and posterior aspects of the disc space. In healthy spines, there is a very strong correlation between the change in disc space height and the amount of rotation. That forms the basis for a standardized test to detect rotation-dependent changes in disc space height. Vertical instability can be measured and reported as a standardized metric as was done with the FIST index. We call these metrics the anterior disc widening index or ADW index for short, and the posterior disc widening index or PDW index. Here is an example of a spine with an abnormal ADW index. This is one common abnormality pattern, where ADW is high. FIST is normal. The superior vertebra seems to be hinging open at the facet joints, so there is likely severe facet impingement that could be contributing to symptoms. And the disc vacuum sign appears in extension. This is also commonly found with high ADW. Using the ADW metric, it may be possible to learn how this affects patient symptoms as well as what is the best treatment option. It is reasonable to hypothesize that surgical stabilization may help. More evidence is needed. Here are prevalence data for ADW abnormalities, both for ADW greater than 2 that includes even modest instabilities, and for ADW greater than 3 that includes only the more severe instabilities. As with the FIST index, ADW abnormalities are more common in patient populations where instabilities might be expected. Vertical instabilities are also found in a small percent of patients enrolled in disc arthroplasty and biologic treatments. ADW abnormalities are also observed at adjacent levels. Here are some recommendations. Obtain high-quality flexion extension radiographs with good patient effort. Use rotation and/or translation measurements alone with caution. Rotation-dependent translation may help diagnose shear instability. Disc widening metrics may help diagnose vertical instability. More evidence is needed, but these metrics may help to resolve a long-standing dilemma. Is fusion needed in addition to decompression when treating a spinal stenosis patient?